All right, here's our roadmap for this explainer. First, Foley catheters and management. Next, bladder trauma and ruptures. Then, diverticula and interstitial cystitis. After that, we hit bladder cancer basics, followed by managing that cancer. And finally, we'll wrap up with acute versus chronic retention.
Section 1. Foley catheters and management. Now, sizing a Foley might seem basic, but it's actually misunderstood all the time. That French grade, it doesn't measure the diameter, it actually measures the outer circumference. Just pure geometry here, 2 pi r. And check out the color coding. A 10 French is yellow, 12 is white, 14 green, 16 orange, all the way up to an 18 which is red. Oh, and if you ever come across a 3-way Foley catheter with that extra third channel, that's specifically designed for irrigation to prevent clot retention.
So, you can't just grab any catheter off the cart. The material literally dictates the timeline. Your standard rubber catheters, those are purely for short-term use. We're talking a maximum of 7 days, mainly because of the higher UTI risks. But on the flip side, silicone Foley catheters are the absolute go-to for long-term needs, especially in bedridden patients. They can safely stay in place for up to 35 days with way less bacterial colonization.
Okay, imagine you're at the bedside, and a Foley is completely, stubbornly stuck. How do you manage it? Well, rule number 1, absolutely do not yank it. That will severely rupture the urethra. Rule number 2, don't just pump more water in hoping the balloon will burst. That just causes nasty internal trauma. The safest, absolute best management here is an ultrasound-guided suprapubic puncture of the balloon. It's simple and it works. Now, if your problem is just per-catheter leakage, where urine is just leaking out around the sides, that's an easy fix. You simply inflate the balloon a tiny bit more or just upsize to a larger Foley.
Section 2. Bladder trauma and ruptures. When that trauma patient rolls through the doors following a severe pelvic or abdominal impact, you have got to immediately figure out exactly what kind of internal damage we're dealing with.
Basically, we're looking at 2 main types of bladder ruptures. First up is the extraperitoneal rupture, which is definitely the more common of the two. It's heavily associated with pelvic fractures. Clinically, what are you going to see? The patient won't be able to pass urine, they'll have this deep perineal hematoma, and crucially, you'll see blood right at the tip of the meatus. That's a massive red flag for a possible associated proximal urethral injury. On the other hand, the intraperitoneal rupture is less common, but the mechanism of injury is actually kind of fascinating. Let me paint a picture for you. Imagine a guy playing in a local corporate cricket match. He really needs to use the restroom, but he holds it in to stay at bat. So his bladder is just completely full, totally distended. Suddenly, the bowler delivers a fastball that smashes him directly in the lower abdomen, right above the suprapubic area, and he instantly collapses in a syncopal attack. Why? Because his bladder was at maximum capacity. That blunt force caused it to literally burst straight into the peritoneal cavity. Urine leaks everywhere, causing instant agonizing peritonitis. For a stable patient with this presentation, your go-to investigation is a CT urography. But, and this is a big but, if the patient is unstable, you stick to a standard cystogram. As for treatment, an extraperitoneal rupture usually just needs a catheter for about 7 days. Our cricket player's intraperitoneal rupture, though, that requires a full-on laparotomy and a 2-layer surgical repair.
Section 3. Diverticula and interstitial cystitis. All right, let's step away from the acute trauma bay and take a look at some of these chronic structural conditions.
Bladder diverticula essentially act like extra little pouches on the bladder wall, and they come in 2 main flavors. First, you have congenital diverticula. You'll usually find these right in the midline, running anterosuperiorly near the persistent urachus. Thankfully, they typically don't get very large. But pulsation diverticula? Totally different story. Just like the name implies, these are caused by increased bladder pressure, literally pushing the wall outward. We see this all the time in patients struggling with BPH or some sort of bladder outlet obstruction. They tend to form laterally, right near the uretic orifices. And this is a really critical point. If these pulsation diverticula get massive, they can actually compress and block the ureter entirely, triggering a cascade of severe downstream complications. And that brings us to a really fascinating clinical tell, the double urge symptom. Imagine your patient goes to the bathroom, successfully empties their bladder, feels great, but the exact second they stand up and change posture, boom, they feel this intense urge to urinate all over again. Why does that happen? Because all that residual urine that was hiding inside the diverticular pouch just sloshed right back out into the main bladder space. It is such a classic symptom. Now, if these diverticula become really large and symptomatic, causing recurrent UTIs or acting like a factory for stone formation, the definitive management is surgical removal, a diverticulectomy.
While we're on the topic of chronic bladder issues, we absolutely have to talk about interstitial cystitis, which is also known as Hunter's ulcer. This is a relatively uncommon condition, primarily seen in female patients. They'll present with chronic pelvic pain, increased urinary frequency, and this constant uncomfortable feeling of overdistension. If you go in and perform a cystoscopy, you'll spot this very characteristic linear ulcer sitting right at the fundus of the bladder. Biopsy that tissue, and the pathology is going to show lymphocytic infiltration. To help manage this incredibly painful condition, the standard approach is using hydrostatic distension or administering dimethyl sulfoxide.
Moving on to Section 4, Bladder Cancer Basics. Look, if a patient presents with painless, gross hematuria, bladder cancer absolutely has to be at the very top of your differential, no question. And while things like ultrasounds and urine cytology are helpful tools, firmly confirming that diagnosis absolutely requires a cystoscopic biopsy.
When we're assessing a patient's risk, we need to categorize the specific type of bladder cancer. By far, the most common is transitional cell carcinoma, or TCC. You can easily lock in the risk factors for TCC using the 3 Cs: cyclophosphamide, chemicals, specifically aniline dyes, and cigarettes. The second major type is squamous cell carcinoma, which is commonly seen in Africa. You can remember its risk factors with the 2 S's, smoking and schistosomiasis. That's a parasitic infection that causes a premalignant condition known as bilharziasis. We also have adenocarcinoma, which typically sprouts up near the persistent urachus or the trigone. Oh, and for you genetics fans out there, mutations in the NAT2 and GSTM1, sometimes called the mu gene, are heavily implicated in germline bladder cancers.
All right, once you actually get that cystoscopic biopsy, the pathologist gives you the T stage. And honestly, this dictates the entire game plan. TA is your non-invasive papillary carcinoma. TIS is carcinoma in situ. If it's T1, that means the tumor has breached the epithelium and is sitting in the lamina propria, right above the muscle. But T2? T2 is the critical threshold. This is where the cancer actively invades the muscle layer itself. T3 means it's broken through to the paravesical tissue, and T4 means it is directly invading adjacent structures. Also, don't forget the grading. G1 is well differentiated, sliding all the way down to G3, which is poorly differentiated. And guys, here is a crucial high-yield fact you need to memorize. If this cancer spreads, the very first lymph nodes it hits are almost always the obturator lymph nodes.
Section 5. Managing bladder cancer. When performing that initial cystoscopy, the surgeon absolutely has to take a cold cup biopsy right at the base of the lesion. Cold means no heat, no cautery whatsoever. You need this completely pristine tissue sample so the pathologist can accurately stage the cancer without any artifacts.
Once we get that precise staging back, our treatment plan follows a very clear progression. For a superficial, non-invasive talker disease, you might literally just observe it, or maybe use a single cycle of intravesical chemotherapy like mitomycin. If we're dealing with T1, meaning it involves the lamina propria, or if it's carcinoma in situ, the patient is going to receive 6 cycles of weekly intravesical BCG immunotherapy. It's actually kind of wild. They literally have the patient roll around every 15 minutes to make sure the fluid coats the entire interior of the bladder. But if that cancer hits T2 and becomes muscle invasive, we are in advanced territory. Management at this stage requires major upfront surgery, specifically a radical cystectomy, and that's often combined with the MVAC chemotherapy regimen. That's methotrexate, vinblastine, adriamycin, and cisplatin.
Now think about this. If you perform a radical cystectomy and remove the patient's entire bladder, you obviously have to engineer a new way for urine to exit the body. The most common non-continent urinary diversion we use today is the ileal conduit. Here's how it works like a giant puzzle. The surgeon takes a small segment of the ileum, let's call it segment B. They isolate it but keep its blood supply completely intact. Then they anastomose or reconnect segment A directly to segment C. That keeps the digestive tract moving normally. Finally, they attach the ureters right into that isolated segment B and bring one end out through the abdominal wall as a stoma, where the urine just drains into a collection bag.
While the ileoconduit is currently our gold standard, it's definitely not without its risks. The most common complication you'll see is a stricture forming right at the site where the ureter anastomosis to the ileostomy. Now you might be wondering, why don't we just attach the ureters directly to the colon? You know, a ureter sigmoid anastomosis. Well, we don't do that because the complications are absolutely severe. When feces mixes directly with urine, it causes massive UTI risks, plus this nasty condition called hypochloremic metabolic acidosis. And even worse, it carries a literally 100 times increased risk of developing adenocarcinoma right at the anastomosis site. So yeah, That is exactly why that specific procedure is practically abandoned today.
Section 6. Acute versus chronic urinary retention. Let's wrap up our rounds today by looking at this super common, yet surprisingly easily mismanaged clinical scenario.
Differentiating between these two is absolutely essential. Acute retention, that happens fast. The patient is going to give you a very short history, like maybe a stone just got stuck, and they will be in intense, agonizing pain. But because it just happened out of nowhere, their kidney function tests, or KFTs, are going to be perfectly normal. Chronic retention, on the other hand, is super sneaky. We see this all the time in BPH patients. They'll have a long history and is completely painless. Why? Because the bladder has just slowly stretched out over months or years, becoming this massive, easily palpable balloon. And most importantly, because of all that prolonged back pressure up the system, their KFTs will be heavily deranged. You'll actually see their urea spiking significantly higher than their creatinine.
So how do we treat them? Well, both get a catheter. But here is the massive, glowing red flag when it comes to chronic retention. Gradual decompression is absolutely mandatory. Think about it. If you take this massively distended chronic bladder and you empty it all at once, that sudden, massive drop in pressure is going to cause all those stretched out blood vessels to just violently rupture. You'll trigger a severe, intractable hematuria. You absolutely must drain it slowly, step by step, and ensure the patient is heavily hydrated afterward to support those struggling kidneys.
To close out our explainer today, I want to leave you with one final, really critical question. We've covered trauma, catheters, structural defects, and even oncology. But when we're dealing with bladder cancer, what is the absolute single most important prognostic factor for patient survival? Think back to those critical staging thresholds we discussed earlier, because that single factor, the depth of muscle invasion, that T stage, that's what dictates the surgery, the chemotherapy, and ultimately the patient's entire future. Thanks for joining me on these rounds today, and keep digging into those clinical details.